to Chapter 18, General Pharmacology for the EMT. So some general information about drugs. Each drug is typically listed by its generic name, and it will have at least three names. So it'll have a chemical name, it'll have a generic name, and it'll have a trade name or a brand name. Aspirin is one of those, so the chemical name would be acetylsalicylic acid, and the generic name would be aspirin, and then Bayer would be like the trade name. So things that you need to know when you guys give a medication is indications, contraindications, side effects, and any kind of untoward effects. When you look at why you're going to give that drug, that's the indications. And then contraindications would be anything that would suggest a reason not to give that medication. So like patient there's also absolute contraindications and relative contraindications. Would be a reason not to give that drug. Side effects, those are things that the medication causes as a result of taking that medication. It's just a side effect that has been known to been caused by this medication. There's really no like set standard side effect for most drugs. And then untoward effects. This is something that happens when the drug is given. We know about it. It's just something that we have to be aware of. So you also have to know what kind of medication that comes in. So there's various different kinds of forms. These are just a small list of the ways you can give a medication. So when you administer medications or assist with medications, it is a serious responsibility. You have to know the medication, and you need to use good judgment with using that medication and giving it. For the EMT, there's really not there really isn't a drug that you guys give that causes major harm to the patient. It's more when you're talking like the advanced levels and given ALS drugs and various things like that you get into being dangerous with those medications. So for authorization, there's a couple different things. So there's offline medical direction where you don't have to speak to a physician. It's basically standing orders or protocols that say, because the patient is doing this, you can give this medication. Online medical direction is where you speak to that physician directly. You then listen to what they have to order, and then you repeat the order back. And then, of course, if you have clarification, ask it. If the order doesn't seem like it's supposed to be there, or you feel like it's a bad order, or not necessarily a bad order, but an order that would negatively affect the patient, then you probably shouldn't do it. So there are 5 rights to patient medication administration. Right patient, right time, right medication, right dose, and right route. Depending on who you ask, where you look, There may be a sixth one, and it's just the right documentation. So when we look at these 5 rights, it goes on every single time, every single patient, every time we give a medication of any kind. So you have to ask yourself, do I have the right patient? Is this the right time to administer this medication? Is this the right medication? And is the dose that I'm going to give the right dose? And then also look at the right route. Okay. So this is a medication cross-check. I've added it in here, just kind of. It's a conversation that you and your partner have, basically to say, hey, I'm going to give this med, and they're going to confirm that you have the right medication and everything like that. So routes of administration, there's a few different kinds of routes. So you can do oral or swallowed, sublingual, which is dissolved under the tongue, and then aerosolized, which is inhaled or breathed, and then intranasal or intravenous as well. There's IM, which is injected into the muscle. Subcutaneous is injected under the skin. It's like you're pinching the skin and getting into that subcutaneous level of the skin. It's best if you give it in like the butt or the bicep, is where those particular shots go. And then intraosseous is right directly into the bone. You use a bone drill in order to get into it. You can do endotracheal, which is sprayed directly into the tube, kind of like aerosolized. And then there's also intradermal. Intradermal is like your TB test. It's not going all the way to the subcutaneous level or the muscle. It's just kind of right there on the top of the skin. So pharmacodynamics, these are the study. This is the study of medications on the body. So what kind of effect this medication is going to have, how this medication will affect my patient specifically, and what kind of patient factors change how medications work. There's a lot that goes into pharmacodynamics, including pharmacokinetics, the way the medication works on the body, and it's just, there's a lot. So in general, this is the way the medication works and how it's going to affect my patient. So patient-specific factors that can change. So if you've got elderly patients or patients who have cirrhosis of the liver or anything like that, the medication may not work as well, and you may have to have a bigger dose or something like that because of the fact that all medications go through the liver to get weeded out, basically. So what the liver does is it breaks down the medication and it says, hey, this is the stuff that I want, this is the stuff that I need, but this I don't need, because some medications, they have to bind to other things in order to get into the body initially. Okay. And then after administering that medication, we're just going to reassess the patient and then clearly document all those medications administered. So there are several different types of medications that the patients can take on their own. They're prescribed to them by a doctor. They're not medications that we give them. Advair is one of those those medications. There's several others. All of these right here, these common drug suffixes, kind of give you an idea of what that medication might do. You don't necessarily have to know the medication itself, but if it's, say a Pril, okay, that's an ACE inhibitor. Um, it's an angioconverting enzyme inhibitor that deals with the heart. Um, there are like lisinopril and captopril. So these are antihypertensives. So if I know that I've got some type of pril, it's probably an ACE inhibitor. Okay, and it works for blood pressure. Beta blockers as well. Those all end in lol or lol. Atenolol, propanolol, labetalol, metoprolol, all of those things. And really, it's not just an antihypertensive, but it also works on the heart rate to slow it down. So it's just one of those things that the more you do this and the more you look at those medications and see what kind of medications those patients are on, the more you'll kind of have an idea of what those things are. Yeah. Herbal agents. So we still need to know what those herbal agents are that the patients are taking, because it may be affecting um, their medications that they're prescribed. So you've just got to be aware that sometimes some of these things can, like St. John's wort, it can uh, potentiate other things, um, other medications. So, all right, so let's look at the meds that you can give on your own with like protocols, um, doctor's orders, whatever. Um, let's look at those meds. So aspirin, oral glucose, oxygen, activated charcoal, Narcan, and albuterol. We'll take a look at each one of these things. Okay, so aspirin, it is a platelet aggregator. It helps basically to prevent clots from forming. We give it for chest pain. Contraindications include bleeding disorders such as like GI bleeds or recent GI bleeds, or esophageal varices, or anything like that. Maybe they have active bleeding. If they are having a stroke, we don't want to give them aspirin necessarily, and we do not want to give aspirin for a head injury either. Um, Side effects include increased risk of bleeding, and then our dose is 324 milligrams. We give it chewed, so that way it is buccally absorbed, so in the cheek. And yeah, and we also get the 81 milligram tablets because those are the chewable kind, and they're not enteric coated, meaning that they have some type of coating to protect itself until it gets to the stomach. Oral glucose, this provides for glucose to be used by the cell. We give it for hypoglycemia. Contraindications would be that the patient is unconscious, they're unable to swallow, or they're unable to follow commands, or they have some type of vomiting. Side effects can be nausea. Most all medications have some type of side effect of nausea, and possibly vomiting. The adult dose is 15 grams, and then the pediatric dose is as needed up to 15 grams. So we don't necessarily have to give the full 15 grams. If the patient starts to come around, hey, great. And we only gave 10 grams, that's fine. Okay. And again, this one is buccally or taken through the cheek, absorbed through the cheek. Oxygen, this provides oxygen for cell use. Indications include hypoxia and dyspnea. There aren't a lot of contraindications, but there are two things that we have to be cautious in. Well, one thing cautious, one contraindication. So paraquat poisoning, which is a specific pesticide, and oxygen can actually increase the problems with that pesticide. And then we want to use caution in use with COPD because although it is rare, patients have this hypoxic drive that, or COPD patients have this hypoxic drive that basically runs their O2 levels and their entitles and their CO2. In a normal patient, our body tells us to breathe because we're low on, or we're high in carbon dioxide. In a COPD patient, it's the opposite. So they're high in oxygen. So they have this hypoxic drive, basically. Adults, 1 to 6 liters on a nasal cannula, 10 to 15 liters on an on or breather mask, and 15 liters for a bag valve mask. Kids is the same way, okay? And it's given through the nose or inhalation. Activated charcoal, so this absorbs toxins in the stomach. So basically what it does is it coats the substance in the stomach, and it absorbs it all and doesn't allow it to release its medication. Okay, so it's given for oral overdoses, ingestion of toxic substances such as carbamazepine, phenobarbital, quinine, and theophylline. Okay. Contraindications would be caustic substances such as acids, alkalis, or petroleum. Unconscious patients as well, and then severe altered mental status. Only because it is given by mouth and it's swallowed. So if the patient can't swallow, obviously we can't give them anything by mouth. Okay. Side effects include nausea, vomiting, which is kind of what we want, and then a black tarry stool. Even though you've got to be aware that, you know, if your patient goes to the bathroom and, oh my gosh, they have a black tarry stool, they have a GI bleed. No, if we give an activated charcoal, we should expect some type of black tarry stool. Okay, they can also have constipation. And then the adult dose is 50 to 100 grams, comes in a tube, basically that you give the whole thing. And a straw, and a cherry little flavoring packet. It does not work, by the way. And then constipation is another side effect. Narcan, this is given for an opiate or opioid antagonist. Indications are respiratory depression from that opiate or opioid. Contraindications would be a non-opiate or opioid overdose, such as crap, I lost it. Marijuana. Okay, you can't give it to a patient who has taken marijuana because it won't work. Other contraindications are unconscious for an unknown origin. So if we don't know that they have an opiate or opioid overdose, we don't necessarily want to give the Narcan because it's not that Narcan is going to hurt them, but if we give it intranasally, then it is going to hurt them down the long run, because if we just keep giving it because we think it's not working, or we think that they've overdosed when they haven't, and we just keep giving it because it's not working, so we just need to give more. You know, our thinking is that we just need to give more. Then we're just going to fill their lungs with fluid. Brain tumors, and then, of course, if the patient is conscious, do not give them Narcan. Side effects include nausea, vomiting, emotional upset, or anger, because what have we just done? We've taken their high away. Okay. Adult dose is 2 milligrams in the little spray, intranasal spray, and then pediatrics is 0.1 milligrams per kilogram, up to a max of 2 milligrams. When we give anything by nose, it is given 1 ml per nair. Technically, you're going to do 1.3 mLs per nair, because of the fact that you've got to include dead space in the actual nostril itself. Albuterol, this is a bronchodilator. It's given for wheezing, COPD, asthma, bronchospasms of any kind. Contraindications include tachycardia, because of the side effect of tachycardia. So if our patient is above 150, we don't necessarily want to give it, or we want to give it very cautiously. And then if they have a hypersensitivity to it, or they have pulmonary edema or rales. Adults is 2.5 to 5 milligrams. It comes in a little squeeze bottle type deal, already pre-dosed. So you just set up your albuterol treatment, put your albuterol in there, and then you just squeeze a little deal in there and then you put it on your patient. It is inhaled or nebulized with oxygen at 6 to 8 liters per minute. We talked about Narcan. Okay. These medications you can assist the patient with if they are prescribed it. Okay. It has to be the patient's own medication. So inhalers, nitro, and epi. So bronchodilators, inhalers. So these are used in patients with asthma, emphysema, chronic bronchitis. It enlarges those constricted tracheal and bronchial tubes. Side effects include an increased heart rate and patient jitteriness. Nitro, this is given to patients with chest pain. It helps to dilate those coronary vessels to make them bigger. And then contraindications include a low blood pressure or taking medications for erectile dysfunction, such as Viagra, Levitra, Cialis, any of those things. Because nitro itself Viagra itself was initially an alternative to nitro. Was the theory and the reason it started out. And then they found out, hey, it gives guys boners, so we're just going to give it for that instead, because they can make more money. Anyway, so low blood pressure, I think your book says 90. I would probably not give it to a patient who has a blood pressure lower than 100 systolic, just because of the fact that in my realm as a paramedic, I don't like to give nitro without even having an IV started, no matter what the blood pressure is. I'd rather have that IV started. And then a side effect is that dropping blood pressure. So if you've got a patient whose blood pressure is 90 systolic and you give them nitro, depending on what it's going to do to the body, it could drop it into the 70s or 60s, and then you've got a real problem. Epi auto-injectors, so these are given for patients who have severe allergic reactions or anaphylaxis, and they've had an anaphylactic reaction before. It is a vasoconstrictor. It relaxes all those smooth muscles and airway passages. And then the side effects include an increased heart rate and blood pressure. Okay, so these are the needles for each one. They're pretty long, and they're designed to go through clothes, and they're really, really thin and can break off as well. to skip that video. Force protection medications. So there's different ones. If you get deployed with the military, you get prescribed a duodote, which is just an atropine auto injector for like nerve agents. IV therapy. So there's a couple different things to know about IV fluid administration. There's some stuff that it goes into, and when we do skills, we'll go through how to set one of these up, and I'll explain everything that goes into it. But the three most important things that it has is the drip chamber, the flow regulator, and then a drug or needle port. The drip chamber is basically how fast that medication is going. We can see. And then it also has a flow regulator or a roller stopper type deal. Clamp, I guess, rolling clamp is what that is. So when we do this, we do want to make sure that we follow kind of an aseptic technique where when this cap comes off of this, it does not touch anything other than going inside of the IV bag or the fluid bag. Right here. And then down in his left hand is the flow regulator or the roller clamp to kind of determine how much is going to flow into the drip chamber and into our patient. Wide open is just going to run a steady stream of fluids in, and then as you close it off, it's going to get slower. So there are some issues that can come about with IVs. So you can have your flow regulator left closed. You can have your clamp closed on the tubing. The tubing can become kinked, or the tubing can be caught under the patient or equipment. These are just kind of things that maybe we need to look for if we're not getting any kind of flow from the IV bag. And then you want to monitor your IV sites for any kind of infiltration. If you have any questions, let me know, and I will answer those as best as I can.